Well, welcome to our final session of the day, Medicare and Medicaid for the next 50 years, Insights from the Top. It's been a long day, so I thought we might liven things up a bit by giving everybody a quiz to get started. So here's the quiz. Listen to this description carefully, and then I'm going to ask you what it's about. The task was enormous. Millions of beneficiaries had to be notified and signed up. The federal government had to set up a new record system, figure out how to pay for services, and manage a host of other details. It had to publicize the new services, explain the choices, answer questions, and track people who signed up. And the government had to set up contingency plans if the rush of new patients overwhelmed the healthcare system. This is a description about what? Okay, well, it's because you all are with NASI. You know the answer. This was what it was inherent in setting up the Medicare system back in 1966. Some of the folks who were involved in this are no longer with us, but as we well know, their successors had other things to deal with. Implementation of DRGs, standing up of Part D, the creation of the Medicare Advantage program and its multiple named predecessor programs, debates over hospital cost containment, successive waves of Medicaid expansion, and so much more. That excerpt that I read to you is from this great book, The Heart of Power, Health and Politics in the Oval Office, that David Blumenthal and Jim Marone wrote several years ago. And it's about the healthcare reforms as seen from the perspective of the presidency and the people in the Oval Office. These folks were not at the heart of power, but they were close to it. Did anybody see the documentary 20 Feet from Stardom? Yeah. Yes, about the backup singers who were, they're sometimes much more talented than the front people, that they were mostly more talented. Yes, exactly.
I mean, nothing personal.
The Mary Clayton, who was the woman who sang that famous riff from Gimme Shelter, rape, murder, family-friendly lyric that was, et cetera, just terrific voice. So it was about these people who really, they created the parts of the song that we're still humming to this day, the bridges, the hooks, and all that. In many instances, they were more talented than the people who were at the front of the band. I don't want to draw complete parallels to the cast of people that we have here. But these were the folks who were not necessarily getting all the power and the glory, but actually were doing a lot of the very hard work. And so what we're going to try to do today is plumb their knowledge of being at the helm of these two very important programs for various periods of time, and what they take away from that experience that they think will be applicable to the next 50 years. So let me introduce them. Right next to me here is Leonard Schaeffer. He's the Judge Robert McClay Whitney Chair and Professor at the University of Southern California. He was the then memorably named HCFA Administrator under Jimmy Carter in 1978 to 1980. Next to him is Gail Wilensky. She's a senior fellow at Project Hope. She was the HCFA administrator in the first Bush administration from 1990 to 1992. The first administration, the only administration of the first Bush, I guess is the way to say that. Okay. Next to her is Bruce Vladeck. He is senior advisor now for Nexera Incorporated. He was the HCFA administrator under Bill Clinton from 1993 to 1997. And finally, Tom Scully is with us. He's senior counsel at Alston and Bird. He was the CMS administrator. In fact, it became CMS while you were...
HCFA administrator for a week.
Yeah, for a week, right. HCFA administrator who became CMS administrator under George W. Bush from 2001 to 2003. So I asked each of these folks to reflect back for us. First, give us a sense of a seminal moment running either Medicare or Medicaid or both during your tenure that you thought was indicative and reflective of the nature of running these programs. Then I asked them to think about something that is going on in the present with respect to these programs that represents an extremely important trend and potentially a point of departure from the past. And then I asked them to project forward to the next, maybe not all the way to the next 50 years. They have great crystal balls, but nobody's is perfect. at least give us a sense of where you think things might be going. And we've heard a lot about some of the potential earlier today, whether it was Medicare Essential, as we heard about this morning, the conversation we just had about universal Medicare, or any of these realistic possibilities over the next several decades. So with that, let's start with the past, or look back at the past and those seminal moments. And Leonard, I'd like to begin with you.
I was the youngest serving administrator, and I think I'm now among the oldest living administrators. And as Tom frequently points out, I ran HCFA just before the Civil War. We didn't have any of this fancy interweb stuff or, wireless phones. We had to do it all ourselves. The issue back then, it's hard to believe, even at this event, was that Medicare came from the Social Security Administration, and it came out of the value system that said these are people that have worked hard all their lives, they've paid their taxes, and they deserve to get their check on time. So the focus, the Medicare Bureau was to get those checks out, and the bigger the better. The opposite end was Medicaid, which at the time I entered had just come out of something called Social Rehabilitation Services, and their focus was on rooting out fraud and making sure nobody got a payment that was inappropriate. But if a claim was submitted by a legitimate doctor or a hospital or whoever, pay that thing as fast as you can. And the goal in both organizations was to pay quickly and to pay fully. I had come from Illinois, and I've been responsible for some programs. I was the director of the Bureau of the Budget, and paying fully was not the goal unless you got value for money. So I was originally the Assistant Secretary for Management and Budget at HHS. I was having these conversations with Secretary Califano, and my point was, these two programs taken together, largest single purchasing entity for acquiring healthcare services in the universe. And if we made them healthcare programs as opposed to transfer programs, and if we use that leverage to acquire what we wanted, we could get a higher quality and lower cost. And so the issue was, how do you merge Medicare and Medicaid? That was the fundamental issue. We did three things. One was to move them, integrate them, move them to the same location out in near Baltimore. The second one was to try to develop a set of values about this is a healthcare program, not a transfer program, and we have obligations both for quality and cost. And the third thing was to convince the Congress that this is what we were doing. And I think there was some success if you look back on the first two. I think the third was an utter failure. And I think there are a few people who might remember. I went up to the Hill with something called the Uniform Hospital Reporting System, which was a system to acquire all the data that we still don't have about the hospital care and costs in the United States. And it was explained to me that Medicare, or the federal government, has no business asking clinicians or hospitals to fill out forms, literally. I had members of Congress say that. So we didn't quite convert Congress, but I think in terms of the institution, HCFA, it worked well, and that organization stayed in place, okay? Because one of the goals was to build an institution that would buy the appropriate services for the appropriate people until somebody came along and changed its name. And the point I'd like to end on is when I left HCFA, everything was going great.
And the transition was seamless and all was well in the land. So Gail, seminal moment of your tenure.
Well, I'm going to do what I was initially thinking of the seminal moment seemed even more appropriate for what has the clearest bridge to issues going forward now. I'll spoil the suspense and say it was the introduction of the relative value scale and where we're now thinking in terms of going with regard to how we reimburse physicians. For me, what was a seminal moment was a dual effort with my friend over on my right, Tom Scully, and that was getting a unanimous consent to put a stop to the, or at least to put a a barrier up through regulations to the voluntary donations provider taxes that the states had been adopting with enormous speed and great creativity as a way to take what had been a matching grant program, Medicaid, and convert it into an only federal increase in expenditures program by these very creative financing mechanisms. It was an issue that had been brewing for at least a couple of years. And it had reached a point where the states were shameless in terms of their activities, bragging to the papers about how they would put in place these voluntary donations whereby the hospitals would put up some money, they would get the match would come in, and they would have their money returned to them. So that, again, it was only the federal money that was in addition.
And these were presumably some of the states that now are resisting taking any dollar from Washington to expand the Medicaid program.
They were a mix. Actually, some of the most egregious are, one was West Virginia. That was the starter of all of this. Pennsylvania was particularly egregious. But frankly, it was so widespread that it became hard to tell who was and wasn't. It did teach me a lesson to never question the creativity of state officials. It required, because of the timing and the legislative cycle, a unanimous consent. I think that the department didn't seem to mind my engaging in this, along with Tom Scully, who was at OMB, as the PAD, because it was widely assumed in the department and probably maybe in the White House as well, that there was no way we would succeed. And we spent several weeks, morning, noon, and night, trying to convince senators in particular about the necessity of having this become a more regularized program and going through the process, whatever they thought about whether more money should be devoted to Medicaid. And to our, and definitely the Department and White House's great surprise, it passed. So for me, the seminal moment was that, as unlikely as activities may seem, sometimes with an enormous amount of work and a lot of luck, you can make things happen that you don't expect will. In some ways, even more seminal moment, and therefore the one linking to the future, if it's okay to get there, is that the implementation of the relative value scale occurred during my tenure. It had been passed into law right before I was sworn in November of 1989, scheduled to be implemented January 1st of 1992. The fact that it hadn't even been finished in concept, yet alone in an implementable way, did not bother the Congress. And it was the major focus of all hands on deck activity to make sure that physicians would be able to be paid under this new system January of 1992, because of the disruption that would clearly occur for seniors if that were not to happen. My mantra kept being, you can have it done right or you can have it done on time, but you aren't going to get both. Since in the law it's being done on time, that was what we were aiming for. It was enormously frustrating as a market-oriented economist to put in this massive redo of a price-administered fee schedule. I don't know whether it was poetic justice or having just bad karma from a different life that put it on my tenure. But finally, we seem to be coming into a more sensible set of strategies with the legislation that has been proposed but not funded in terms of how to try to move away from the volume-driven, expenditure capped, rarely imposed system to one that rewards and encourages physicians to behave in ways that are more socially responsible for the Medicare program.
And it only took about 25 years.
Only
so
took, yes.
it's moving
Yes.
at lightning speed. So Bruce, seminal
Well, again, I'm
moment.
going to digress for just a minute because I'm not sure either Gail nor Tom knows it. Well, when I started at HCFA, even before I was confirmed, my first project was negotiating the rules implementing the law they had gotten passed in '91 on taxes and donations, where the agency had issued proposed rules at the end of the first Bush administration, which had engendered so much anger and controversy from the states that they were withdrawn so that the incoming president, the former chairman of the Health Committee of the National Governors Association, could see that they were rewritten more responsibly. And I spent 3 or 4 months in negotiations with the NGA to come out with the new rules, which actually I think work pretty well given the statute and are pretty much still the ones in place today. They've been modified and expanded to address some of the new gimmicks the states came up with in a variety of ways. But they also have never been fully enforced, but that's a whole nother question. The states still owe CMS several $billions that nobody's ever going to see. But the inflection point that I want to talk about was actually 2 events that were not sort of terribly visible that happened close to one another in 1994, but really changed my way I thought about the job in the agency, and I think set some things in motion that are still relevant. One was we had the annual release of the hospital death data scheduled for the spring of 1994. That's a story Gail lived with for a long time, and in preparation, we got together with all the staff to talk about what we were going to do and what they were doing and how they refined the model and all that kind of stuff. And I posed the question, I was listening to this discussion, I posed the question, if we took the resources we're spending on this and put them into something else having to do with improving quality of care to Medicare beneficiaries, what could we do? And they went nuts in terms of the number of ideas that emerged in the next 15 or 20 minutes about opportunities to really do something about quality that would have a much larger impact than the 0 impact on actual medical care that this press excitement was having. And a couple months later, we had a young public health service officer working in the administrator's office on detail who came to Helen Smits, my deputy, and then to me, and showed us an advanced copy of that week's issue of MMWR, which reported on the first large clinical trials of the use of AZT to prevent maternal fetal transmission of HIV-infected women. And within the week, which I think was the all-time record, we had a letter out to state Medicaid directors about and sending along this information and about testing and improving access to testing for pregnant women and so on and so forth. We got all the manuals changed and everything. So that within a remarkably short period of time, for a variety of reasons, of which that was only a piece, the rate of newborn infection with HIV fell almost to 0 in most of the large metropolitan areas in the United States. But both those things convinced me that the boundaries that had existed within the department, that HCFA did health insurance and health care and cost policy and so forth, and the public health service and those guys did medical stuff and clinical stuff, was no longer sustainable. We recreated the position of chief medical officer, and we began recruiting clinicians, of whom on our payroll, on our line as opposed to on public health service lines, there were literally fewer than 15 or 20 outside survey and certification in the entire agency. And that began or continued, but put, I think, a significant momentum behind, given some of the people we recruited, recognition that being an effective purchaser of healthcare increasingly, it was impossible to maintain boundaries between that which was insurance and that which was clinical. And that if you wanted to get the best value for the taxpayers' money, you really had to better integrate expertise about the two and thinking about the ways what you should pay for it and how you should pay for it. And that's obviously now sort of a central focus of much of what the agency does.
Tom,
So I
from
don't
your
want to use my
perspective.
time here to get sucked back into the provider taxes and donations thing, but I came from Tennessee at about 2 o'clock, and it's still raging in Tennessee. I was down there yesterday. So it's, I think we all probably, if we were Medicaid directors, would do what the Medicare directors do. My frustration with that program is that you got 56 different state and territorial programs that have different rules. And when you have a $600 billion program, back for 30 years, every state's got a different set of rules. Susan and I are on the Dartmouth Med School board together, and last time I checked, Dartmouth, New Hampshire doesn't put one penny into its Medicaid program, hasn't for years, and pulls about $120 million out for road building. So I always say, it's live for free or die. But
Slogan for a
the
reason.
issue is every state has a different deal. And if I were a Medicaid director, I'd do the same thing. But we have a program that's the second biggest program in the government that has such scrambled egg rules, and it's basically a state-run program. One of my frustrations at CMS is that everybody spent 95% of the time on Medicare, and Medicaid is such a complicated program. And I'm trying to pick on people. I would do exactly what Tennessee's doing, but there ought to be some. If you're going to run a railroad that big, there ought to be some consistent rules state by state, and that's always been frustrating. But I'm not going to use my time. Just to get back, the two things that really shaped me at CMS probably happened when I was with Gail. I was at OMB. My first project coming in with President Bush 1 in '89 was with Bill Roper, also a former HICF administrator. He was in the White House, I was at OMB, and we had to pass RBRBS and then handed it to Gail. And at the time, it was a bipartisan deal with Rostenkowski and other people. It was the right thing to do because Part B was out of control, and I was proud of it. And then 3 or 4 months later, my second job was to save catastrophic, which is a drug benefit, for which I got run over by a freight train.
Good thing that worked.
Yeah. So the two reasons that left me when I came back to HICF CMS 10 years later, it left me with two things. One was I watched RBRBS those years, and Bruce and I have disagreed respectfully with this over the years. I just decided administrative pricing doesn't work. And I think the administration has come to this conclusion in the last week that, whether you like it or not, the government fixing prices by the unit creates a volume explosion, doesn't work. And at some point, you're better off going to capitation, whatever the bundles are. So that drove my view when I came back in, that the government is much better off, as much as you may or may not like insurance companies, to regulate them appropriately, give them a 5% margin and say, let's do lots of bundles and put them together and drive to full capitation, which when I got to CMS, Medicare Plus Choice was 2.7% of the program, and I was a fervent advocate, and still am, that the government ought to, as fast as it can, get out of the administrative price business and try to transfer the risk to somebody other than the Treasury has the risk and will run the program better. So that assumes you can regulate them appropriately and give them a tight margin. But I'm a fundamental believer that the more you can capitate, the better, and that was one thing that I got out of my experience with RBRBS and why I spent a lot of time. We came up with any Medicare Advantage and spent a lot of time. You could argue about whether we ever did it or not. We're charging the Medicare risk program. And the other thing was, because I felt strongly seniors need a drug benefit, when catastrophic got repealed, I came back, and I really went back to CMS to develop a drug benefit. And, I just think seniors need a drug benefit. It was irresponsible that Medicare didn't have a drug benefit. Some people thought we did in Part D was cheap, but we're cheap Republicans in our direction, which President Bush, I think, admirably said, which most Democrats didn't take as seriously at the time, was come up with a market-oriented, non-administered pricing drug benefit. And we did it, and at the time it was incredibly controversial. It's not anymore. And so I think, and if you look at where pure capitation has worked and private sector transferring the risk with 3% margins in large volume worked in Part D, it's worked pretty well the last 10 years. You can argue there's too many choices. At the time, people think there were enough. But those two things really, the catastrophic being repealed and RBRBS kind of drove my thinking, and I think what I came back and tried to do.
So all of you have described this job as being a mix of amazing sort of frustration, but also incredible opportunities to shape the system. The frustration part being chasing after provider taxes, basically
Dealing with Congress.
Dealing with Congress, exactly.
Minor
Worrying
issue,
about getting the checks out the door.
Dealing with the rest of the executive branch.
Right, et cetera, et cetera. But also, all of you have talked about the opportunity, Leonard, you started, to basically rethink using the program, the purchasing power of the government to improve health. Tom, you using the power of the government to create a new system to get prescription drugs into the program. So taking those two themes, this sort of mix of just the day-to-day drudgery of administering these complex programs and the complex system, but also the amazing opportunities to push things forward. Let's go to the present now. What do you see as what falls into those two categories not just for the people who are running the program today. We had Pat Conway here today talking about this announcement this week on moving toward more capitation, moving away from fee-for-service. But this combination of the opportunities now in place to really push things forward and some of the challenges that they're going to have to be grappling with. Leonard?
Well, again, my daughter describes my early life as when everything was in black and white. It was before color movies and color television. Back then, we had much greater flexibility than any of these folks because nobody understood the law. In Congress or even in the administration. And there was also something, I think it was called Section 223, which allowed you to do demonstration projects independent, of anybody else. You just sort of set them up. And I think the problem you have in, quotes, reforming healthcare is there's a lot of good academic work and there's a lot of good research, but you don't know what's going to work unless you try it. And as has been mentioned, there's creativity at the state level, but there's real creativity at the hospital level, and physicians are pretty good too. So you need to experiment. And I think what's happening now, although I think it's going to be chaotic, is there are quite a few different ways of looking at paying for healthcare services. We got the bundling and the ACO thing and the blending, which I find very interesting. It's going to be chaotic for a while. But out of those, I think there's some potential if there are people in the agency who can spot what works and then spread it around to make some important changes. But it's going to be very chaotic, and it's going to occur, and we can talk about this later, in an environment where we may be running out of money or at least running out of patients. But I think that's the big opportunity now. There are a lot of different things going on, and people inside CMS can choose and try to pursue this, that, the other thing. One caveat is the states have tremendous discretion as well. The implementation of the ACA is not terribly consistent with the law as written, but it gives the states an awful lot of discretion. So there may very well be some very good ideas that come out of state administration. But I think we're going to be in a chaotic situation, which ain't so bad if the agency can spot the things that work and populate that across the country.
What do you think about that, Gail? Is that you see those same opportunities?
The most frustrating, and I'm sure that Leonard had more than a share of this experience, is that people don't understand that what a regulatory agency like HCFA CMS does is implement the law that Congress writes. It turns out Congress doesn't always understand that that's what a regulatory agency does, and I got to experience it, as I'm sure all of my colleagues did, when we released the proposed rules and then ultimately the final rule for CLIA, the Clinical Lab Improvement Act, which put in place standards, proficiency standards and other requirements for the clinical labs. And it required the same everywhere in the country. And I can remember being out somewhere in a rural area, one of the many experiences of going to places that I never knew I had a need to go visit, like Chester and Jordan, Montana, for example, with Senator Baucus.
There's a good reason to visit there.
Yeah. Being asked, this was not him, by a member of Congress, of how can you possibly expect a lab in rural Iowa or Utah or something to have the same capabilities as in Manhattan. And it was like, don't look at me. That's what the law says. I didn't write it. That's what you passed. So having people understand that while there's a lot of flexibility that comes with implementation, from the least you need to do in order to implement the law as written to the most you can possibly do and not go outside of the law, and there's a big space in between those two markers. Nonetheless, you are constrained by what the law says and not in a position to create new laws. And many people that you talk to who are having some frustration with Medicare. Physicians or beneficiaries don't really understand always that difference. And as I said, Congress doesn't always seem to understand it as
And
well.
that certainly ties to implementation of the ACA.
And this, one of the changes that has occurred, which all of us have commented on in recent times, is the increasing partisanship that has occurred over the last 20, 25 years. Not that it wasn't partisan before, but so much more so now. And the issue that I had stumbled on was there were provisions in the detail of the RBRVS as written that made it impossible to implement it as it was written. It was a reminder about why Congress gets in so much trouble when it tries to rewrite micro-prescriptive legislation involving operations about which it typically knows very little. And we ended up putting out a proposed rule that only was consistent with part of the law because it was impossible to be consistent with both of these issues on the law, requesting a rifle shot fix to clarify what we thought was the intent and to be able to proceed. So the kinds of issues that you had to struggle with in having this day-to-day activity have been the ones that we hear now, but taken on in a different environment. What is so impactful when you are running the program is you spend most of your time in the day-to-day skirmishes within the department, between the department and the other parts of the executive branch, or on the Hill, although I had a quite good relationship with many of the members of Congress that I had to deal with. But it was really getting out, which you are forced to do and want to do, and being reminded how many people are impacted by these two major social welfare programs, Medicare and Medicaid. And that part was really the gratifying aspect, and I know all of us have experienced that. Whatever your frustrations, and there are many, in terms of trying to implement and run this very, very complicated two programs, it is going out and seeing what a difference it makes in the lives of many Americans, and particularly the most vulnerable Americans, really motivates you to run back and sort of, head back into the skirmishes and try to do better.
So Bruce, I want you to address this notion of the frustrations and the opportunities as you see them playing out for the people who are administering those programs now, and then we'll start to edge, we'll get the same from Tom, and then I want to start to move us toward the future, because the future is soon to be upon us.
I just want to, given what both Leonard and Gail said, I want to suggest that the hardest frustration, because it's an intellectual challenge and it's one the political system really deals with in one way but not another way, is as we experiment with all these new payment systems and all these new approaches and these new institutions, I hope no one insists on finding the one that works best everywhere, because I think what we're going to find, as we found throughout the history of the Medicare program and the Medicaid program, this country is so heterogeneous, and the health systems in this country are so heterogeneous, that one size can't possibly fit all. That's one of, and how you figure out what has to be uniform in terms of benefits, in terms of financial protection for beneficiaries, in terms of basic standards of quality, and what ought to vary or be permitted to vary, and how you permit individual communities and health systems to do different things if they're meeting basic goals is to me the sort of primal intellectual challenge of running the Medicare system. Congress views it all as how many dollars are coming to my congressional district, and increasingly sort of micro-legislates. When we started PPS in 1983, and everybody said, we're going to have uniform rates, and I said, yeah, for the first Congress. I said, but give it 20 years, it'll look like the Internal Revenue Code. And in fact, we now have, anybody's ever worked on Area Wage Index, which I had to spend a lot of time on, we have 4,000 PBS hospitals and like 3,000 different categories of area wage index. So
I thought everybody got their wage index in New York City.
Manhattan's actually lower than Nassau County now, so I don't understand any of it. But the point is that how you make national policy and provide a uniform set of benefits nationally in in rural Montana and in New York City and is very difficult. And neither our legal system or our political system accommodates that very well. And of course, the role of local elected officials traditionally has been to make sure that everybody gets the same except the people in their district who get more. So that sort of complicates it very substantially. I think the other thing that people miss, and it's members of Congress and its beneficiaries and it's everybody else, is Medicare is very powerful and very influential. It's a very important part of the healthcare system. That doesn't make it all powerful or omnipotent. There are a whole lot of things that the program can't do. There are a whole lot of things the program shouldn't even try to do, like require people to do advanced directives. But there are lots of things that even if you wanted to, it can't, and or shouldn't. And understanding what is within the capability of a federal regulatory agency paying a lot of money under very specific and often highly detailed statutory instructions it's hard to remind yourself of. I mean, you have to keep reminding yourself of it, but it's something that's very, very hard to explain to all the people who want you to do something different from what you're now doing.
Tom.
So 2 seconds on the CMS. So first of all, it was the most fun job I've ever had. It was, intellectually interesting, fun, more fun even than the White House and OMB, I hate to say. So, it was, and the staff I think were great. So it's a great place. But I think moving forward and switching the gears, I do think in the future you can see what's coming to some degree, and I think it's frustrating for me in the politics. I have made a lot of good. I actually like Max Baucus a lot. And I had a lot of, back then it was a lot easier to have bipartisan relationships. It's gotten tougher. But if you look at what these guys are talking past each other, where you say Republicans hate premium support, hate Obamacare and hate the ACA. Democrats hate premium support for Medicare, and you look at them and say, it's the same thing. If you're under 65, Obamacare is premium support. You're buying people a basic benefits package, and you're subsidizing a premium support level, and you can buy more or less if you want a gold plan or silver plan. And then Democrats say, well, I hate Medicare premium support. It's a terrible thing destroying the Medicare program. Well, the premium support Medicare is exactly the same as the ACA if you're under 65.
Yeah, but the people in the ACA had nothing. People in Medicare have something better.
Let me just finish. But the point is, when you go back and but if you go back and look at the structure and them talking past each other, my point is, when you look at this, the issue is who do you want to subsidize how much? That's the issue, and that's a legitimate issue. I have violently object to the ACA, not because I don't like it, and I've had a discussion with Bruce a lot. I think it's crazy to cover people to 40% of poverty, which is 62% of the population, and I think the benefits for that level are too high. We had the same debate over Part D. Democrats wanted a Part D benefit 3 times as plush as we wanted. That's a legitimate debate, but we're not talking about that too much. We have these great debates about Democrats hate the ACA and Republicans hate premium support and Democrats hate the ACA. Structurally, if you look what's happening, you get 72% of people that I can tell in Medicaid capitation now. The ACA is 100% private plans, and Medicare is now 31% private plans. The world is moving towards, if you were going to ask most Democrats 25 years ago, what's the model you think would work? A lot of them would have said the Federal Employee Health Benefits Plan. If you asked a Republican, they would have said, what's the model that works? They would have said the Federal Employee Health Benefits Plan. The issue here is we're moving towards a capitated system of people buying private plans, and the real debate, which I don't think we have enough, is who gets subsidized at how much. I would spend a whole lot less and subsidize fewer people with lesser benefits. But we're not even having that discussion because these guys get in opposite trenches and throw grenades at each other all day. So I guess my point, if you asked Ron Wyden and Paul Ryan, who are the 2 most important guys in the next decade in healthcare, they actually agree on 90% of this. They actually both like this model. They both, we go back and look at it as whatever you want to call it, the Alan Entov and Paul Elwood model from 25 years ago. And I think we don't have enough of those discussions about, we get too much of everybody's against what the other party's doing. And that's, I think, where the nasty partisanship is unfortunate. If there's any hope I have for the future, it's that I think Ryan, who most Democrats probably think is an evil, terrible conservative, and Wyden, who's a great guy most Republicans probably don't know, are very like-minded, very smart guys. They would probably violently disagree on what the subsidy should be, but that's where the system's moving, is an FEHBP-like system. I think it's moving inevitably in that direction. I think it's what the future is. And the real debate should be, who do you want to subsidize for how much? I would emphatically vote we shouldn't be covering people to 400% of poverty. And I think that was crazy. That's the reason why I think the ACA shouldn't have happened. It was that we subsidized too many people. But the structural debate, philosophically, is just stupid.
Well, just to pull us a little bit out of the weeds of the current environment and think about the long-term future. We had a lot of discussion today about the changing demographics of the country. How will be a majority-minority population somewhere between 2040 and 2050. That's within the next 50-year time frame. We talked a lot about the aging of the population and how the fastest growing group of people will be the 85 plus. We talked about Alzheimer's and other conditions that are going to increasingly affect those folks unless we come up with cures. We talked about the complex needs that some portion of the population is going to have and how increasingly complex that's going to get as we get this aging cohort. And then we talked a bit about the new face of Medicaid as a consequence of the ACA. It's a different program. It's going to be a different program going forward than it has been in the past. So if we sort of roll all that up and think about the next 50 years, if you were sitting up on a cloud and we all came to you and said, give us the pearls of wisdom that will guide us through this enormous set of changes that we have ahead of us, based on your experience, what would you say, Leonard?
What would I say, we're going to end up, or how we're going to get there?
Oh, pick one. Pick one.
Well, demographics is destiny. And what is happening is the Medicare is going to become more and more expensive no matter how you cut the rate of increase in healthcare costs, because of the number of people that are going to become Medicare eligible. And we have now dramatically expanded Medicaid, good thing, but Medicaid now covers almost 20% of the population. So we are going to have a very, very expensive undertaking, and it is unfortunately growing as a percentage of government spending. If you look at the CBO projections, you see that everything except Medicare, Medicaid, interest on the debt, and Social Security actually costs a much smaller percent of the GDP in the future than it does now. So I think we're going to be faced with some very serious financial issues now.
An opportunity on the opportunity side?
Well, I think it will force change, but I think the piece that's hard for people to understand. I was at a meeting with the former Ben Bernanke, the former chairman of the Federal Reserve Board, and he mentioned that his opinion, the United States government was basically a large insurance company with an army. And the problem is we can afford the army, but we can't afford the insurance company. The irony is, the next week I was at a meeting with former Secretary Gates, and he said the single biggest security problem the country faces is the fact that over 50% of our debt is funded by non-Americans, and that what's driving it is healthcare costs. So what's driving the debt is healthcare costs. So I think there's the potential for an unholy alliance between deficit hawks, nothing personal, Tom, and national security guys to say, and ladies, to say we got to do something. And that something, worst case, will be across the board cuts, because that's easiest. That's what the sequestration thing was all about. Best case, it'll be targeted, but very hard to do. So I have to say I'm not as optimistic as some that we're going to see a nice future. Second law of American politics is old people vote, poor people don't. So if we have to cut costs, we may see that some of the good things that have happened for the most vulnerable may not expand, but coverage for older people is going to stay. So I'm a little more pessimistic than some, and I would like to be talked out of my pessimism.
Okay, well, let me reframe the question, and let's emphasize opportunities.
Opportunities.
To see whether we can get to a...
The opportunities are, under the threat of cost reductions, people will do some interesting things. And if we can convince doctors and hospitals that the crunch is real, you might get some real creativity.
Gail.
I want to touch on something Bruce raised, which is I think is very important, and then go forward with that notion. There's a lot of innovation being tried now in the private sector, sponsored by the Innovation Center, by other parts of Medicare. The question of trying to figure out which of these many innovations works, has some legs, improves quality and lowers cost, or at least does one of them, and keeps the other constant. And how to try to encourage and promote so that you recognize it won't work everywhere, but you want to try to have it take root, or something take root in as many places as possible, is going to be a huge challenge. I'm very concerned, probably because of being jaundiced by our past activities, where even good innovations just seem to die on the vine as to whether or not we'll be able to identify, support, and help get them implemented in some way, which will be critical because, as has been mentioned, I'm sure endlessly at this last 2 days, we have the doubling of the population on Medicare in any case. If we go back to anything like the rate of increase in spending, which historically is what we've done after these stable periods, may not happen if we can figure out a way to really change incentives and drive some of the change in a way that's appropriate, but still will be a challenge. Then we'll get on to the question that I think was very accurate, that, as Tom phrased it, which is how much should we subsidize various people and in what kind of way allow them to go forward. We have some very weird things in Medicaid right now, which at some point we're going to have to face, like the poorest people, the ones who were originally on Medicaid, get their states get less support for them than the higher income people who are newly on Medicaid because of the ACA expansion. Having two different rates is not sustainable, although CHIP has been hanging in there for a while. But it makes absolutely no sense, CHIP again is a model of this anyway, to have the higher matching for the higher income of the low income population. We're going to have to do something about that. We have differential subsidy rates for people who are getting subsidized to buy insurance in the ACA at 200% of poverty line, compared to those who are at 200% of the poverty line who are having employer-sponsored insurance, some cross-subsidies within their employment, and minimal amounts of tax subsidy because of the tax system. That makes no sense. Those kinds of differentials just drive disequilibrium as people sort out to try to get the best thing that makes sense for them. There is this irony that Tom raised in terms of a fixed subsidy given your income to choose among private plans among the ACA that should have a familiar ring, and the struggle about how much of that do we want in Medicare, as Medicare Advantage is now in the low 30% of the population. We're going to have to try to figure that out. But those are not insurmountable questions. It's just going to require us to have a more frontal discussion about how much subsidy for whom than we've normally have been comfortable doing in this country. I don't know whether we're going to be pushed into that because of all the dynamics that Leonard raised.
So unfortunately, I've been informed the future has arrived. So we have about sort of Twitter length spaces left for Bruce and Tom. Any final comments either of you wants to make?
The optimistic scenario, which Gail has heard me say before, is one of the effects of demographic change. We're going to have to keep people in the workforce a lot longer than they have in the past. That'll be okay because they'll be healthier and they'll be more likely to do white collar or non-work than in the past. And that changes the economics of the social welfare programs in ways that haven't yet been fully evaluated. The pessimistic view, which I'm more likely to subscribe to, is that the enemies of the welfare state have managed to kill everything the federal government does except Medicare, Medicaid, and Social Security. That's why there's so little left in the discretionary programs. That's what's left in their sights. And if we don't do something about the tax code and about the distribution of benefits from the tax code over the next decade, they're going to be increasingly vulnerable as well, because this is not a historical accident. This is the result of a very intentional, long-term strategy that is succeeding. And Medicare and Medicaid are the next targets.
Tom,
So I won't
last
take
word.
that. So first of all, it's not just Medicare and Medicaid anymore, so you got to change the name back to HCFA, because it really is now Healthcare Financing Administration. I don't know who the dope was that changed the name to begin with. But the second thing I would just say is that we rapidly disagree on policy, but we've all been friendly for a long time. And that's one of the nice things about HCFA is that it is a big administration, and there's 95% of it is not political. And I think Marilyn Tavenner, who's leaving, has done a great job. And I think mainly in the most intensely partisan time I've ever seen. You ask most Republicans, I hate the ACA, I can't stand President Obama, but Marilyn Tavenner's pretty nice. I mean, that's a pretty remarkable thing to pull off. And to a large degree, I think all of us had to deal with that. And I think CMS, I don't know the new guy, Andy seems like a nice guy, but and it's an intensely political job, and I think everybody here had to deal with that. And I think it's best served when the agency is less political.
Well, if you enjoyed this fireside chat, let me tell you that there's going to be more of this to come under the Academy's Oral History Project. 2 decades ago, at the 30th anniversary of Medicare and Medicaid, the social historian Ed Berkowitz of George Washington University interviewed the then 8 living former CMS HCFA administrators as part of an oral history. And now, working with Academy staff, he's going to update the historical record, interviewing and in some cases re-interviewing the 22 former administrators and acting administrators about their tenure.
I changed my story substantially.
Did you? Okay, good. Well, we have it on tape now, Leonard, so we can check, right? So the Academy is going to be presenting CMS with these interviews to be added to the historical archive over there as the Academy's gift to the nation on this important anniversary. So, yes, some people will be grateful, Leonard. I know it will be hard to believe. So check back in July to learn more about the results of this project. Before we go today, just a few final announcements. Please, once again, fill out your blue evaluation forms if you have not done that already. Turn that into the NASI staff as you leave, and you'll get your complimentary NASI flash drive. So you have incentive if you fill out that form. It's really been a terrific pleasure for me and my co-chairs to help bring to you this conference today. We do have to once again thank a few important people. The top sponsors of the conference, ARP and the Robert Wood Johnson Foundation, as well as the California Healthcare Foundation and Daimler. We'd also like to thank WellPoint, AHIP, the Siegel Group, and U.S. HealthWorks for sponsoring our receptions. Once again, on behalf of Sachin Jain and Karen Davis, we really want to thank you for helping us, all of you, helping us to put this on. The conference truly, though, could not have happened without the tireless efforts of the Academy staff. Pam Larson, why don't you all stand up if you're here? Pam Larson. Virginia Reno, I think Virginia's not here. Lee Goldberg is here. Christine Quinio, Devin Cowens, Jill Braunstein, Elisa Walker, and Ann Fenley, all of whom have been really central to the conference planning. And thanks all of you for your very hard work. So thanks to all of you. We hope to see you at other NASI events over the course of the year. And of course, be back here 50 years from now for the 100th celebration of Medicare and Medicaid. Thanks all of you. And join me in thanking this panel for a great discussion. Right.